COVID-19, who and what to trust. Science communication has been terrible during this pandemic. Look at the masking messaging alone. Is it a cloth mask? Is it a medical mask? An N95? Source control? Are you using it for personal prevention? And how about physical distancing? It's physical distancing, not social distancing. We need to stay socially connected more than ever while maintaining our physical distance. And then when it comes to therapeutics, hydroxychloroquine, remdesivir, plasma, steroids, vaccines. Do you intubate early? Do you intubate late? Do you have them lying prone? To date, the whole thing has been a bit of a dumpster fire. So who and what do you trust? Well, it can seem like we're drinking from a fire hose. And I understand why people are feeling overwhelmed with information. If you look at scientific publications alone, just on COVID-19, in the first 6 months of the year, 24,000 articles. And if you include preprints, you add another 20,000 articles up to October of this year. That means there's more than 200 articles being published on COVID-19 every day. Are you keeping up? I'm not keeping up. And then there's traditional media. In the first 5 months of this year, there were 39 million individual articles published from English language traditional media outlets alone. So just traditional media, first 5 months of the year, English language alone, 39 million. More than 1 million of these articles are considered misinformation. This large amount of misinformation has been coined the infodemic. And don't even get me started about social media, tweets, Facebook, Instagram, TikTok. It can be exhausting and overwhelming at times. So who do we trust? What do we trust? How can we get that signal from all that noise? Because what we're looking for is poos, not do's, loos, or moos. Poos are patient-oriented outcome. Is the patient alive or dead, which would be a good example. Not disease-oriented outcomes or do's. Is the chest x-ray resolving? Or lab-oriented outcomes, like viral load. Or a monitor-oriented outcome, a moo. What are their O2 sats doing? So we're looking for poos, not do's, loos, or moos. Not only is it how do you figure out the signal to noise, but how do you implement the evidence once you have that signal? And I love this meme on changing protocols during COVID-19. Like literally, it would change more than once a day. Masks, shields, goggles, protected codes, testing that we're doing, treatment options. And it was amazing how many clinicians felt that they were all of a sudden experts at clinical epidemiology and biostatistics just because they went to medical school. Just because you were smart at one thing does not mean you're smart at other things. Well, at the same time, how many epidemiologists thought they could tell a clinician how to practice clinical medicine, but had never treated a COVID-19 patient? So my advice, be skeptical of everything you hear about COVID-19. The time to accept a claim is when there's sufficient evidence. And those making the claim have the burden of proof. It's called a burden because it's hard, not because it's easy. And if the burden is not met, we should accept the null hypothesis, meaning no superiority. And science doesn't make any claims about the quote-unquote truth, but it is rather the best method we know of for exploring the natural universe and the most reliable way of determining the point estimate of an observed effect size. You could go with a Bayesian approach and say a COVID-19 publication is probably wrong. If you did that and you did nothing else, you didn't do a critical evaluation of the literature, you'd be right most of the time. Why? Because John Ioannidis famously argued in his 2005 PLOS article, most research findings are false. And given the quality, or lack of quality, research published on COVID-19, I would suggest that the pretest likelihood of a published finding is false is even higher today than it was 15 years ago. Now, clinicians and researchers have been throwing the kitchen sink at COVID-19, and I understand. They've been trying medications like azithromycin, steroids, famotidine, IL-6 inhibitors, chloroquine, hydroxychloroquine, remdesivir, vitamin C, zinc, etc. A shorter list might have been, what hasn't been tried? They've also tried convalescent plasma and are testing various types of vaccines. I have been disappointed to see what seems like science via press release. I mean, just look at remdesivir as an example. There was a White House press release claiming, quote, significant positive effects. And we all wanted to see the data, publish the study. Well, when it came out, it was a randomized control trial of just over 1,000 patients, and the significant positive effect was a decreased time to recovery from 15 days down to 10 days, so a 5-day difference, but no statistical difference in mortality. More recently, we've had the WHO Solidarity trial published, and it was an order of magnitude larger randomized control trial. So it had more than 11,000 patients in it, and it found little or no effect on hospitalized COVID-19 patients treated with remdesivir. And this was based on overall mortality, initiation of ventilation, and duration of hospital stay. Convalescent plasma is another example with the FDA commissioner, who made a mix-up between absolute reduction and relative reduction, which he quickly apologized for. But there was a claim of a 35% relative reduction in mortality, which sounds fantastic, but it turned out that it was only a 3% absolute reduction. But it was a reduction in mortality. But we need to be clear that this was only an association based on an observational study. It was not a randomized control trial of convalescent plasma. So correlation is not causation. And a final thing about press releases is this month we've had a press release about a potential vaccine claiming 90% efficacy. And today, just today, another press release came out about another vaccine claiming more than 90% efficiency. What did they mean by that? What was the population? How long did the immunity last? Were there any adverse events? Lots of questions. So publish the paper, and after proper peer review and post-publication peer review can be performed. To avoid any confusion and being labeled against vaccination, here is my view on the topic. Vaccines cause adults. There is much work is being done on getting a COVID vaccine to market, but that's at least months, if not years away, and we will not know how effective the vaccine is, how long the immunity lasts, and the safety profile. So what do we want? Evidence-based medicine. When do we want it? After peer review. Dr. Simon Carley et al. Published an article in the BMJ Evidence-Based Medicine speaking about the urgency of COVID-19 represents both a threat and an opportunity for EBM. They encouraged critical reasoning, critical appraisal, and critical thinking during these COVID times. Our response to COVID-19 should be based on science and not on emotions, politics, or economic issues that challenge it. And you know what? As Richard Feynman famously said, it's okay to say, quote, I don't know. Don't get frightened by not knowing things. Feynman says, I have approximate answers and possible beliefs and different degrees of certainty about different things, but I'm not absolutely sure of anything. End of quote. This excellent opinion piece called Reminder to Reason was published in the New England Journal of Medicine this spring. The authors said, quote, we are living through an unprecedented biopsychosocial crisis. Physicians must be the voice of reason and lead by example. We must reason critically and reflect on the biases that may influence our thinking process. Critically appraise evidence in deciding how to treat patients and use anecdotal observations only to generate hypotheses for trials that can be conducted with clinical equipoise. We must act swiftly, but carefully, with caution and reason. So in conclusion, who and what do you trust during COVID-19? I would encourage you to be skeptical of anyone and anything, including the nerds. Thank you.